Good morning. Good morning. Come on, it's Monday. Come on. Good morning. Here we go. All right. Everybody's had some coffee now, so we're good, right? Good morning. We're going to go ahead and get started. I will let you know right off the bat that this is a casual convening, okay? So if you need to go out, restroom or make a phone call or take a call or whatever the case may be, feel free to do so. We do expect you to do that, all right? My name is Doug Hogan. I am the Communications Director here at the Foundation for a Healthy Kentucky. I'm not Susan Zepeda, as your agenda indicates. Unfortunately, Susan is out sick this morning. She's not feeling well. It may have been something that she had at one of the neighborhood cookouts last night. So that could be a story in and of itself. Just saying. But we are excited to have you here this morning. We really are. Of course, at the Foundation for a Healthy Kentucky, we strive to make Kentucky a healthier place to live, work, raise a family. We make grants, we do research and polling, invest in pilot projects, and really work to ensure that the health policy deliberations in Kentucky are informed with the best information possible. We try to provide that data. We hope that today's conversations and storytelling techniques and other ideas you hear will help your health news really to jump off that page, leap through the speaker, and through the TV screen. You kind of get the idea there. And I know it's kind of broadcasting puns that probably some of you don't like. My background's in TV news, 18 and a half or so, in front of the camera for about half that time, and then behind the camera for the other half. And I know how difficult it can be to try and tell health stories. And whether you're in broadcast or you're on the print side, you all have a specific amount of space or a number of seconds or minutes that you have, and you can't go over that allotted time. And it can be difficult in telling some of those stories and really getting to the heart of the issue, and then make it so that your editor likes it, right? Because there's always that manager who has to, say, I don't like this, or how does my audience feel about this? So, you have to deal with that. And then, of course, the top priority is your audience. Your audience has to resonate with the story, and they have to read the story. So it has to be interesting and entertaining, at least to some degree for them. So those are the types of things that we will be working on today, and hopefully you can get some good tips. While the workshop is targeted to journalists, you look around you, this is a journalist crowd of, for, and by journalists, right? But there's also some communications folks here and others who are journalism students and journalism faculty from various universities across the state. And we think that's important because telling that health story and trying to explain those health topics, as I've said, is very complicated. It's not a simple chore. And we feel that the more that we can help educate and inform those who are working to tell those stories and get facts out, then the better for all of us. We would not be here without the hard work of some folks I want to call out individually, briefly. Larry Ty, who is right here. Larry actually is, a former Courier Journal reporter, a reporter at the Boston Globe. He runs a national health fellowship program, but he's also an author. In fact, Larry is finishing his 7th book. And we looked at some dates on this, and he reminded me that, he's hoped to get another book in, get it out at the end of November, or just coming up very shortly. So, and it's on Robert Kennedy, correct? So, Larry, Al Cross in the back of the room, many of you know. Al is, of course, a renowned journalist, and now at the Institute for Rural Journalism, the executive director there. And Al and Larry, some other folks have put in just a ton of time of their time, their talents, and their energies behind the scenes to make this happy, and we're so glad that they did. Briefly, just for introductions, I want to introduce a couple of staff members that we have from the Foundation. Rochelle Seeger. Rochelle is our Community Health Officer, Health Research Officer. She's the point person for the Kentucky Health Issues Poll. Many of you, I hope, know about the Kentucky Health Issues Poll and that it provides a snapshot of Kentuckians' views on various health topics. Rochelle also manages our data website, which is KentuckyHealthFacts.org, and that has local health information. Local data that you can compare and look at what's happening in your local community. So if you have questions about those topics, you can see Rochelle. Alexa Curley. Hey, Alexa's in the back. Alexa is responsible for, in large part, setting everything up, making sure that we have things on the screens that, you were able to get in the door this morning, lunch, and coffee, okay? So, and lots of other things. Alexa does a tremendous job as an executive assistant, administrative assistant here at the Foundation. They say that Power is knowledge, right? And knowledge is power. Well, we've got a powerful lineup today, and we're starting with an excellent panel discussion to take the temperature on health reform. And these panelists and the other speakers you'll be hearing from are volunteering their time today. So, again, thank you very much for being here with us today as well. We really appreciate your willingness to give a little bit of your time, because I know all of you have extremely busy schedules. And, again, this is a topic that's near and dear to a lot of the folks in the room. Use the day as a networking opportunity as well. If you have any questions, you can see me or any other foundation staff, and we just look forward to an exciting day. So let's get started. Larry?
So Doug, don't go away for 1 second. I just want to say something about Doug here. I run a program in Boston where every year we bring in a dozen health reporters from around the country for 10 days and nights of intensive work on issues from public health to mental health to health reform. And about 5 years ago, I sent an email to Doug, totally out of the blue. He had no clue who I was, saying, we would like you to write a big check to support a journalist from Kentucky to join in this program. And we will give you absolutely no authority in how to pick that journalist. We will not let you help us pick any of the speakers for this program. All we want you to do is write a check. And Doug had enough belief, not in me, because he had no clue who I was, but in Kentucky journalists, and that they deserved a chance to go and learn with 11 other journalists from around the country, that for 3 years, the past 3 years, he's been writing those checks. We've had a reporter from the Courier-Journal, a reporter from one of Al's rural outlets in Kentucky, and we had a reporter a year ago from the Lexington Herald-Leader, Mary Meehan, who did our fellowship program and had a good enough time being away from her publication that she is spending all of this year as a Nieman Fellow at Harvard University. So, Doug, keep writing the checks, and we really appreciate all you do for journalism. I also want to just, before we get started, ask if you could raise your hand, how many people here are working journalists? So about half the group. Well, this program today is intended, obviously, for everybody, but is particularly directed to the working journalists here. And it's going to be half about the issues of health reform and half about other issues about how you cover health issues and can make them compelling, not just for your readers and listeners, but for editors who are really skeptical and say, what do we need another story on health reform? And our panel today is going to help us understand that. I want to just go over really quickly 2 ground rules for the session today. One is that anything that any of our speakers say, we are going to presume is on the record, unless they tell us it's off the record. And the other is that you are journalists, so I don't have to tell you that being rude is okay in a setting like this. These panelists are here, and all of our speakers are here today to respond to your questions. So if people are making speeches and you want to interrupt and ask a pointed question, they will understand, and that's the way journalists operate. And so this is like a mini press conference. And we've got an extraordinary group here, and what I'm going to do is introduce them one at a time and ask them to respond to the first question that they've been thinking about. And since I woke her up early one morning recently, and I think she had no clue who I was or what I was asking. Hello? Well, she was. She was, but she said a very quick yes when I asked about participating. And she is fresh from a major victory of Notre Dame over the weekend over, was it the University of Georgia? Georgia Tech. And everybody here knows Senator Julie Adams. You know she started in the House in 2011. Last year she was elected to the Senate. She is the Senate Chair of the Health and Welfare Committee. She was a councilwoman in Louisville. She's Vice President of Adams & Call, a consulting and engineering firm. And the question that I asked her to think about is, if she were all of your editor and could tell you this is the one story that hasn't been covered or hasn't been covered well on health reform, what is the story that she thinks is most in need of doing?
Okay, I was writing down some notes while we were talking. And I think if you look at the ACA, it stands for the Affordable Care Act. And I think we need to take a look at that first word, affordable. Now that it's been implemented, where are we relative to affordability? Is the ACA is it really health reform? Or is it just, now that we find out, insurance reform? And now that and nothing is free. We all talk about affordability, but somebody has to pay for the Band-Aid. Somebody has to pay for the Tylenol capsule. Where are the costs? That's what we need to look at. And right now, I don't see affordability from the government side. I don't see it being affordable for the provider side. I don't see it being affordable from the patient side. And so what's the problem that we're trying to solve? Kentucky, just the Department of Insurance, all the rates have to come in by June 1st, and then the Department of Insurance decides where we go from this. Kentucky has approved double-digit increases for people who participate in the exchange. So I guess my question is, are we looking at this federal law, and is it doing what it was promised to do? And I would say from a practical application, no.
Great. So from the other side of the political aisle, and from the House Committee on Health and Welfare, everybody here has got to know Tom Birch. He's been the chair of the committee since 1985. He was first elected to the House in 1972, which makes him the longest-serving member in the House history or House today? Close. Okay, great. Well, he's going to someday be the longest-serving member in the history of the House. Right now, he's the longest-serving current member. He was a production control manager at GE, where he worked for 40 years, and he has passed bills to do just about everything in health, from promoting organ donation to studying the homeless to providing safe havens for abandoned infants. And we've just had your Senate counterpart tell us that the most important issue is affordability. What would you like to see people cover here? They're not.
Well, the Affordable Health Care Act is, of course, is the political issue, played back and forth. But what they haven't figured out is that if we didn't have it, and a person goes to the hospital, it doesn't have insurance, they pay 10 times what it would cost you and me if you got insurance to go to the hospital. Now, who pays that? The taxpayer picks up. Nobody records that part of it, and neither has the press, quite frankly, that part of what drives the health care cost. One is, I had the opportunity to spend about 4 weeks in France, and I went there, quite frankly, for a boat ride, and I got taken for a ride while I was there. First thing I did was mention that I'd like to see hospitals. Secondly, I'd like to see daycare. Third, I'd like to see nursing homes. And I went on with a litany of things. Well, the French government set this up for me to see, and it wasn't something that was planned or anything, because I just asked for it, and the next day I got it. But I saw health care delivered in a very good way. They didn't have to worry about the price of it. It was paid for. Their child care was superior, in my opinion, because they really take good care of their children. And the nursing home care, particularly in-home attendant type, that person follows them around. If they want to get out and go shopping, they go with them. We don't do that in America. And we don't focus on that, and neither does the press focus on the fact that we're getting the shaft on health care. The cost of, and I'll use my own example. I had a MRI run a couple of weeks ago. The doctor was worried. I talked to Al about this a few minutes ago. Is that my knee was bothering me from surgery. He said, well, he thought my back was causing my knee to hurt. So I went through that and got in that casket and half an hour and that thing. I come out, the doctor said, well, there's nothing wrong with your back, and if I operated on your back, it wouldn't help your knee. So there went $3,300 out the window for something I knew I didn't need when I went in it. And so we need to get around that. Every country, industrialized country in the world, has health care for their people. England, Canada, you go to any country. Jordan had it when I was there. Israel had it. And France certainly had it. Germany has it. Even Costa Rica, when I was down there for a week, has health care for their people. We're the only country that's struggling and trying to keep 60 million people from having access to health care, yet we pay for it every time they go to the hospital because they don't have a means to pay for it, and the taxpayer pays for it, but it's kept quiet. And the press should be picking up on something like that. Mental health is the next issue that we have. Well, I was only going. I'll pass on mental health. Dental care. Now, you didn't take dental care, did you, Sue? No, I didn't take dental care. Dental care. We have 250,000 people in Kentucky that don't have any teeth. One is gum disease can kill you. Nobody pays any attention to that there. Nobody publicizes it. I've been to conference after conference after conference, and this year, or 2 years ago, I worked with a doctor from Colorado. We set up a volunteer dental program that treated the people who don't have access to dental care. I need $140,000 from the legislature to implement the program, someone who would establish the dentist and then the patient who need to see the dentist. I lost it in the Senate. I'll see $140,000. That would have treated, and maybe got over $500,000 worth of free dental care. But these are issues that I think the press ought to be pushing on if they're serious about health care in this country, because we're only about 5 years away, if I read it right, that we're going to have a single payer plan. That's in the books right now to be done. It's just a matter of when it happens. So we need to get off this kick about affordable health care because we're heading in the right direction. But we need to start focusing on the fact that everybody in this country needs health care, and we need to improve all the accesses to health care. We need more dentists, we need more ophthalmologists, we need more optometrists, we need more psychiatrists. All these things we need, and we need a lot of them in the rural areas, and we do not emphasize that enough. I'm sorry I took too much time.
I know that Julie is anxious for a counterpoint there, and we're going to just hold off on that in a minute. So Sheila Schuster, there would be two ways of introducing her. The quicker way of introducing her would be to tell you the organizations that she doesn't run in the state of Kentucky. But I'm going to take the long road and name a few of the ones that she does run. She's been doing this stuff for 40 years as an advocate, and she's a psychologist, and she's a consultant to the Louisville School for Autistic Children, for the Deaf Oral School, for the Parent Child Center. She runs the Kentucky Mental Health Coalition, the Advocacy Action Network, and Voices for Health. And I think she has a few things to say about mental health and a couple other issues here. Thank you.
Thank you, Larry. I don't want any of you to report that I stopped a legislator from talking about mental health. That would completely undo 40 years of being in Frankfort going, don't forget us, don't forget mental health. So I apologize, Tom, but that was one of my 2 points. So what's the topic in Kentucky that has taken up more broadcast and newsprint time besides Kim Davis? It's the heroin epidemic, right? And before that, it was the pill mill epidemic. So we are talking here, folks, about behavioral health. Behavioral health talks about both mental health, mental illness, and substance use disorders. Think about this. In 2000, we passed legislation that nobody said we could pass to stop systemic discrimination by the insurers against mental health treatment. All right? Up to that time, you could buy a policy and it would say no matter what your diagnosis is, no matter the severity, you're limited to 10 outpatient treatment sessions and 5 days in the hospital if you have a mental illness or a substance use disorder. Now, none of us would buy a policy that had that for cancer, right? You wouldn't say, oh, I'm only going to have 10 chemo treatments or 3 days in the hospital. But because people will admit that they have teeth, and therefore they will always opt for dental insurance, nobody wants to admit that they will ever need mental health insurance. Nobody ever wants to admit that somebody in their family is going to have a behavioral health diagnosis. So there was not a public outcry until people encountered that discrimination. So in 2000, we passed legislation that was historic, and it required large group insurers to have what we call parity. You cannot have any kinds of copay, co-insurance, deductibles, annual and lifetime limits on services on the behavioral health side that you don't have on the physical health side. It was a huge step forward for those of us in the behavioral health community. But it didn't apply to small group, that's under 50. It certainly didn't apply to the individual plans. So one of the things that's never been talked about that I can recall here in Kentucky or even nationally, look at what the Affordable Care Act does for behavioral health. Number one, it says every plan, every qualified health plan and expanded Medicaid has to cover behavioral health, has to have that as one of the 10 essential health benefits. I suspect this is news to many of you, okay? Not only does it have to have it has to have it at full parity. So every individual policyholder, for the first time, when an insurer says, oh, you got to leave the hospital even though your psychiatrist says you need to stay in more days, can say, no, you can't do that unless you have those same kinds of limitations for congestive heart disease or cancer treatment. It's huge. Kentucky, before the Affordable Care Act, was one of the few states that did not cover substance use disorders for all of its Medicaid members. Let me repeat that, knowing what a huge problem we have here in Kentucky. Our Medicaid program did not cover substance use disorders for everyone who was a Medicaid member. Covered it only for pregnant women and for youth. So your providers who are in the community mental health centers, if I'm seeing Bill Wagner and he comes in and he's depressed and he's drinking to his depression, as a psychologist, I can only talk to him about his depression. I can't touch the fact that he's got a substance use disorder as well. Sorry to pick on you, Bill. I'm sure it's not true on either side. Okay. So one of the things that happened with the Affordable Care Act, when we went to Medicaid expansion, which had to include substance use disorders, Governor Beshear said, you know what, we can't have two different sets of benefits for traditional Medicaid, those who are already in Medicaid, and expanded Medicaid. So for the first time in Kentucky, all Medicaid programs cover substance use disorders. Think about the people that are now eligible for Medicaid coverage. Most of them are men who don't have dependent children because those are the ones who were never eligible before. Unfortunately, a number of them are homeless. So you have a lot of outreach in your homeless shelters. Guess what? Probably 50 to 60% of them have either a mental illness or a substance use disorder or both. We call that co-occurring. The cabinet said, hey, we're going to have all these people now with coverage. We need to open our network beyond the community mental health centers. So in January of 2014, Secretary Haynes opened the Medicaid provider network. So now you're not just looking for your stories at the community mental health centers, but you are looking at them from psychiatrists, psychiatric nurse practitioners, psychologists, social workers, alcohol and drug counselors, all of these people that heretofore could not see Medicaid patients are now available to see Medicaid patients. So where the heck are the stories, folks? We've got more people covered in Kentucky for behavioral health issues, 1 million plus, at parity, and I've yet to see that story addressed. And yet look at the huge cost and emphasis that's put on at least the heroin, if not the pill mill. And they're all interrelated, folks. You know, we're not dealing with that in isolation over here. So I have just opened up a huge story for you. Thank you.
Great. Before we go on to Bill, a question that every insurer that I've ever talked to, Massachusetts, where I come from, has had parity for about 20 years, and every insurer that you talk to says parity exists in the law, but there's no way parity exists in practice. Are you saying that parity is in fact happening with those large insurers now, or we're supposed to have it?
I think we're supposed to have it. What happens is that they use something called medical necessity to get around it, Larry. So what happens is that I'm treating a child and I have him hospitalized at one of the psychiatric hospitals. And on the third day, the Medicaid Managed Care Organization or Anthem or Humana says, we're not going to authorize any more days, despite the fact that the treating professionals, the psychiatrists and the psychologists say this kid's barely stabilized. He's not ready to get discharged. And then we have a fight, not because their policy says they only get 3 days. We have a fight over whether they meet the medical necessity requiring hospitalization, and that's a tough battle. We have some tools at our disposal that actually came from the healthcare reform we did in the 90s, and that is in Kentucky we have a very strong external review process, so that if that happens to a patient and the patient is informed through the provider and so forth, they can appeal it to the insurance company. They also go to an outside panel not connected with that insurance company who looks at the record of that child and says, hey, you know what? This kid really doesn't need to stay in the hospital. But you have to fight for it.
Great. So our last, and definitely not our least panelist, actually our first panelist that we signed up is Bill Wagner. And Bill, as probably most of you know, runs the Family Health Centers where he's worked for 29 years and sees 45,000 clients with a little help from maybe a few of his friends there. Bill's program was well known in the state of Kentucky. It became well known and became sort of a lens to see health reform nationally when Abby from the New York Times, who just walked in, wrote about Bill and his program. And there's nobody that I know who knows more about how healthcare reform is working on the ground than Bill Wagner, and we'd love to hear what stories you think people ought to be writing about this if they aren't.
Larry, thank you. Good morning. I normally don't correct the host, but I've actually been there 35 years now, and you must be looking at an old resume there. And a couple of the other things you have written there, I think it's important to point out that I have a couple other hats that I wear because it does help frame some of my thoughts and my thinking. I was also one of the founders of Passport Health Plan. I was formerly chairman of the board, and I am on the board of Passport. So I have I try not to be biased, but it does shape the way I think about the Medicaid expansion here in Kentucky. And I've been the chair of the Louisville Metro Board of Health's Outreach and Enrollment Coalition that's been very actively involved for the past 2 years in bringing organizations and individuals across the community together to help enroll folks through Connect in insurance and Medicaid and into the qualified health plan. So I would like to respond to Julie's comment before I tell you what stories that I would like everybody to cover. But the true name of the Affordable Care Act is the Patient Protection and Affordable Care Act. Some people used to call it PPACA. All right, and we tend to forget that first part, the patient protections that were built into the law that went into effect even before the expansions of the insurance and Medicaid, but things like the guarantee issue, the elimination of the pre-existing conditions, the waiver of pre-existing conditions, the elimination of lifetime limits and annual limits, things like expansion of coverage of children up to the age of 26, all these very important protections that were part of the law that I think we tend to forget about because they were implemented initially. Very, very important. The affordability part of the qualified health plans is still, it's a question that's still out there. Our involvement here in Louisville, we've been very successful in enrolling folks in the Medicaid program, and I'm going to come back to that in a minute. But we've enrolled twice the number that were originally estimated to be eligible for Medicaid in Louisville and Jefferson County. I think based on the state's estimates, we thought there were about 47,000 eligible, and we've enrolled nearly 100,000 people in Medicaid in Jefferson County alone. But on the qualified health plan side, we've been far less successful. We've probably enrolled only a third of those who are estimated to be eligible, and in part, it's because of the complexity of the offerings, the cost, the perception that the penalties or the tax penalty is just sometimes it's better to pay that than to actually go out and purchase
somebody's going to get cut. And I think we can do it. It's not as if the two are mutually exclusive. I had another one. It says, okay, and a lot of times people think that expanding healthcare across Kentucky is wonderful, and it is good, but we have real significant job losses too. We've lost 7,000 jobs in rural hospitals. 7,000 jobs. It says many hospitals in Kentucky already financially strained to begin with, especially in our rural areas, are now operating with even more severe losses. According to the Kentucky Hospital Association, the financial pressures, which include payment cuts of up to $7 billion through 2024, have resulted in hospital staff layoffs and threatened to reduce the availability of hospital care, particularly in rural areas. 65% of 109 Kentucky hospitals so far have reduced staff, eliminating over 7,700 positions. So I guess the story is, it's not that we don't all want health insurance and health care coverage, but we have to be really smart about how we're doing it. And I just don't think that by executive order and eliminating the General Assembly in those discussions has been really fruitful.
But if there were a new governor who wanted to overturn,
he could do it. I don't think that that's the way to go.
would your body stop him?
Here's the thing. We couldn't stop Beshear from implementing it. We couldn't stop another governor from taking it away. That's the significance. I don't think either of them are correct. I think that if you have a legislative body that is responsible for their constituents and their needs, then you have to allow those people to participate in the whole process. I've said it from the very beginning. People used to call me and they were like, hey, my health insurance I'm on private care. My health insurance just got canceled. What do I do? And I said, call the governor. And they go, no, really, Julie, what do I do? And I said, you call the governor. It was his decision to do this.
Do you think would the House stop the governor?
One, first of all, I want to say I was not personally attacking Julie because, quite frankly, we have a good relationship, and we're going to keep that. What I did was attack the philosophy of the party, which, if you watch it is when we did the budget last time, they never referred to the Affordable Health Care Act. They referred it to Obamacare, which, in my mind, creates a prejudice or a bigotry against some person, and which would be the president. And I counted 42 times that, and I'm not going to mention the members that got up on the House floor. Julie was not one of them. But it's why fight something that is necessary? Now it was pushed on us to start with, and the governor grasped it. Okay. Not enough study was enough study. I'm going to take that back. Enough study was done because I did healthcare reform back in the earlier in Brereton Jones's administration, and we almost had it together. Then the governor backed off from it. That was going to be his cornerstone. It crumbled, and I remember we had two more issues to get through on the Healthcare Act, and Kenny Rapier come up and says, "Tom, it's over." Kenny only got two more. It's over. We never offered any more amendments to the bill or anything else. And we had cooperation from both Republican and Democrat. It was a bipartisan issue. But we have got to have health care for our people. We can keep on dancing around the issue. We've got to have health care for our people because it will continue to go sky high until they get it leveled off and we come up with areas of do it. Quite frankly, the legislature has not sat down, at least in my experience, sat down and studied something out like it should be. One is I come out of environment. I spent almost 40 years with General Electric. We had a 5, 10, 15, 20-year plan, and we work for these. State government does not do that. We react to what's out there and try to correct the problem that should have been thought about. So this is not the answer is yes, we should study, we should come together and try to come up with a plan. I'm not for cutting health services in any way, like in child care or in education or children or anything else. These are areas that we should be building on because everybody in the legislature, you know, said this is our future. These children are our future. Yet the first thing we cut is education, daycare, all the things that's important to bring a child to his full potential. I've been fortunate that my children weren't involved in something like that, and maybe most everybody in this room has had the benefit of having a good education. But we have and part of them were the 640,000 people we had with no health care. They had now we're down to close to 100,000 that don't have health care. Some of those that don't want it. And I had a personal friend of mine who was a millionaire. He said, I'm not paying health care insurance. I don't need it. Well, he did finally need it. He's not a millionaire anymore. He got sick. So, you know, we do need it. And the answer is the legislature working together to come up with a proper way to fund it and quit cutting other services in human service. This, under the current administration, because we did not increase our tax base or anything, we've cut over $1 billion out of human services. Last time we did that was under John Y. Brown. If it hadn't been for, I'm going to say, Ron Gary, who was the financial secretary at that time, we went out and collected $435 million in uncollected taxes. We have something like $200 million right now that we could collect would help offset the problem we got now with health care. One thing, we could get out of the wars we're in, and we're spending $100 billion a year to keep troops in these foreign countries. That would buy a lot of health care for everybody. But no, we keep our troops over there. But I could go on, but I know I can't. Well, can I say one other thing? One is, since there's a lot of the press here, I remember, and maybe Al Cross remembers, Tom Mobley. He was a senator, and he attacked the media. And I said, how dumb can that be? We've got people who buy ink by the tank car load, and you're attacking the media. Well, they did. They come back and attacked Tom, and he lost. So be careful what you say at this meeting.
So we could go on having a back and forth here, and I could ask questions all day, but the point is for all of you to be involved. Any questions? This is our only microphone, so I'm going to walk it around. If you just, when you ask a question, just say who you are would be great.
Hi, my name is Tia Clark. I'm from the University of Louisville. I'm a student. My question is, we're focusing a lot on insurance, but isn't there a way that we could focus on making healthcare less expensive, training our administration, our hospital and health administration to cut costs in their private organizations?
I love it, out of the mouths of students. You know, one of the intents of the Affordable Care Act, besides to provide those patient protections, was, as they call it, to bend the curve of health care costs. I mean, I think realistically, we're probably never going to get it to go down, but the question is, can you stop that, you know, asymptote and get it to level off at least, or perhaps to slow down? In response to Senator Adams, you know, the Hospital Association released a paper called Code Blue, in which they touted the problems that they're having. We're also hearing, we were at a Kentucky Rural Health Association meeting on Thursday and Friday in Bowling Green, where the rural hospitals actually feel like they've been saved in large part because of the Affordable Care Act. So, you know, it depends on who you get your story from with any of these statistics. I do think that one of the issues is, in Kentucky particularly, do we have enough providers of all the right kinds? We know in behavioral health and in physical health, if we can get to people early and frequently, we save those higher costs. So one of the questions that I had for you all was, have you looked at those prevention statistics that the governor released last month, think about this. The increase in the number of colorectal cancer screenings and the number of breast cancer screenings and the people that are getting smoking cessation and so forth. And yes, there is that screening cost and maybe even an early intervention, but I can tell you, you can pay now or you could pay a hell of a lot more later. So one of the ways to look is to look at cost offset. You know, are we keeping people out of the ER? Well, one of the reasons that some of the newly insured, whether Medicaid or qualified health plans, are not staying out of the ER is that we forgot to do this other thing. That is to teach people how to use coverage. You're talking about people that have never had coverage, and the only source they know for that care is to go to the ER. So, you know, it's like coming home with your baby and nobody gives you a manual, okay? Somebody gives people a card, and they're like, okay, now the ER will be paid for. That's what people are thinking. No, the card should have said the first thing you do is to find a primary care provider, whether that's a physician or a nurse practitioner or a primary care clinic or a federally qualified health clinic or any of these things. And we should have had tons of information out there. So that's one of the ways to cut costs, I think.
I think it's important that we take a look from the perspective of who is financially at risk for providing that health care. And under the Affordable Care Act, the CMS, the government's created new entities called accountable care organizations. Or in the Medicaid program, we have these Medicaid managed care organizations that are financially at risk. They get paid a fixed amount of money for providing the range of services that are needed by a defined population. So these entities are reinventing the way that healthcare is being delivered, and there's a lot of focus now on trying to bend that cost curve, as Sheila has mentioned. What I am so encouraged to see, especially as a social worker, is that people are beginning to look at the social determinants of health, not just at the cost of healthcare itself once somebody encounters the system, but to look at the home environment, look at the community, look at obviously lifestyles. Poverty rises right to the top. So you know, I'm working with hospital systems now that are identifying their highest cost patients, because there's a small percentage of patients that use the majority of the costs, and it's just across the system, and to identify ways to intervene with those high cost, high utilizer patients. And it's often things like providing them housing, providing them mental health, substance abuse treatment services to keep them out of the jails, to keep them out of the hospital ERs, to keep them out of hospital beds. And so they're really having to reach out beyond the walls of their institutions and look at the broader social determinants. For the very first time, it's really encouraging to me to hear hospitals thinking like that, hospital healthcare systems that are assuming risk. Now, they're straddling two worlds. They're still getting paid per diem for every time they fill up a bed, but on the other hand, they're looking forward to this new way of being paid in the future. And same with the Medicaid managed care organizations. You know, they're taking on a much broader perspective and looking at things like case management and housing and mental health, substance abuse services. It's so encouraging to hear the emphasis on primary care, on behavioral health services, on substance abuse treatment services, on oral health, and on prevention. These were just things that not everybody was paying attention to. They weren't sexy. You know, the sexy part of healthcare was the inpatient, the high tech, you know, the downtown medical center stuff. But things have begun to change as we think about how do we bend that cost curve. So I'm encouraged by that.
Is there enough data out there now that we can look at whether these things are working, that journalists could come in and say, geez, having accountable care organizations or looking at social determinants is actually bending that curve?
Yeah, I think there's some early results that are very encouraging, and the Kentucky One, through a grant from Catholic Health Initiatives, has a pilot project that's looking at their super utilizers, that's matching them up with they're providing home visits. They have peer support specialists or community health workers that's working with these high cost patients to keep them from, first of all, from being readmitted. Medicare has implemented penalties for patients who are readmitted to the hospital, but so there's early evidence that there's significant savings. We've also demonstrated with some of the I hate to use this term, but the frequent flyers are those that cycle in and out of the ERs, that many of them were homeless and had substance abuse and mental health issues, and we've put them into permanent supportive housing, and so we've been able to significantly reduce their cost to the healthcare system. So there's early examples of some real success stories there.
My name is Dana C. with the University of Louisville. And I wanted to know, you talked about those small percentage of those who are high users or have the high cost. Where can we find the information to identify those numbers for that? Okay. Okay.
Tom and I were actually talking about adding a December health and welfare meeting so that we could kind of set the stage before we start in January. And actually, now that the MCOs have been operating in Kentucky for several years now, we want to kind of look at the state of healthcare in Kentucky and how, if managed care has increased a healthier Kentucky population. Because if you start to see those trends, and you start to see, improvements, like we talked about, prevention, screenings, all those things, that dramatically lowers the operating costs for all of these healthcare programs. And so I think Tom and I are, hopefully going to pull that one off in December before we start the session.
Yeah. I know we'll do that. I'm not going to say we're in bed together on this here because that would make my wife very angry. I tell you, Julie is fun to work with, and believe me, the stress of our committee meetings is reduced on my part, because I always felt I was in combat with my former chairman, and she's moved on to bigger and better things. And but the purpose of why we're trying to do this here is to point out the good things that have happened in healthcare since we've done it. One is, preventative care is much less expensive than actually when you get full-blown sick or something. So if you get checkups, which I do every year, and you catch the problem before it starts. Of course, there's no money in preventative care, so there may be some resistance on the other side to keep it. You may not need as many specialists if you stay healthy, and a lot of doctors, and I'm not faulting any doctor, they move on to better things where they feel like they're more suited or where they want to be able to practice. And but we need more primary care physicians out in there. We need more nurse practitioners. We need more occupational therapists, physical therapists, those types of people, because a lot of times you don't need to actually see a doctor. My experience with is when I go to the doctor, it's a nurse practitioner that does a workup on me. It's not the doctor. Actually, he reads what the nurse practitioner wrote down, and it seems to be much easier. I spend maybe 5-6 minutes with the doctor. Actually, you spend maybe 20-30 minutes with the nurse practitioner or a nurse thing. So I think we need to concentrate more on preventative care, and get it done, and get people in tune to getting, and this is one of the things we worked on back in the 80s, was getting people in tune to going to the doctor, not when they're sick, but when they're well, in order to make sure they don't get sick. So I think what we're working on, trying to pull together healthcare costs and what the good things have come out of this so far, and I'm sure there are good things. The cost of it, we have to deal with, because we have to figure a way we're going to pay for it. And I've got a couple of plans how to pay for it. It does not include a tax increase.
Let me suggest to you that you contact provider groups, Primary Care Association, the Kentucky Rural Health Association, the Kentucky Psychological Association. There's a coalition of nurse practitioners and nurse midwives. Providers are seeing these people day to day in their offices. They're spotting the people that they just got the screening results back, and see something there that means that something else needs to happen, and this is somebody who's never had health care or hasn't had health care for years, there are lots of stories out there. And I know one of the things that you all need to do is to put that face on it. You know, we could quote the statistics to you. I could send you the press release from the governor's office about all of the preventive screenings and so forth, but you all really want to see those people and interview them. And I would suggest to you that you reach out to those provider organizations and your FQHCs, your family, your qualified health centers, sorry, I'm blocking the primary care centers and so forth. Obviously, there are HIPAA issues and so forth, but you would be surprised at how many people who have a really successful outcome are willing to tell their story. We've seen it over and over again on the behavioral health side, which has to be the most difficult. But I can tell you, I can put you in touch with consumers that can tell their story about getting treatment. We've had them testify in Frankfurt and so forth. And obviously you want to see that consumer face, and they're out there.
Just want to follow on this same theme. You know, the ROI, the return on the investment on prevention is sometimes many years down the road. You know, and I think we all know intuitively that if we provide, breast cancer screening, colon cancer screening, immunizations, good prenatal care, that there's going to be a savings by having better health outcomes. But sometimes those are further down the road. So the MCOs and the hospitals, the ACOs tend to focus on some of the lower hanging fruit, which is this utilization issues we talked about before. And everybody's trying to reduce ER utilization, right? Get people into primary care medical home, keep people out of the hospital where they're more likely to have more tests run when they're there or be admitted. And so improving access to primary care is one of the goals of my organization and our associates across the state and across the country. But it's a big challenge. We have not seen a big spike up in primary care utilization, even as more people have insurance. We anticipated that we would, but we haven't. It's a kind of a slow, steady crawl. And one of the reasons you've already heard before is that people are used to going to the emergency room. That's where they went when they were uninsured. They continue to do that. We haven't been able to change that behavior. But it's not just a matter of their behavior. It's the fact that primary care practices are not as accessible. We're not open 24/7. We close. We tell people we can't see you today. A hospital can never say that. You know, they're 24/7. Someone goes to the hospital ER, they know they're going to be seen.
How much of an issue with primary care doctors and with dentists is just whether they will see medication?
Well, I think we have very strong networks of providers in our community here, and I think across a good part of Kentucky that have contracted with the Medicaid plans. Now, the dentists, not as many, but on the primary care side, we think there are good networks in place. But here, and I wanted to go there. There's big differences in rural communities versus the urban communities. In the urban community where we are, we're experiencing significant competition from the hospital systems, who are now recognizing the value of primary care doctors, and they're hiring them. You know, many of the primary care physicians now work for hospital systems. They've given up their efforts to exist as independent solo practices or small groups. So they're employed by the big hospital systems, who can afford to pay them more than many of the community health centers can, to be honest with you. And so we're struggling to hire enough primary care doctors. There's already a shortage of primary care doctors in this state and across the nation. And with the competition we have from the healthcare systems, that's our biggest challenge right now, to be honest with you. We've been able to hire more and more nurse practitioners because there's at least 4 schools that are turning out a lot of nurse practitioners, but they don't have the training or the experience that a lot of the primary care docs have in handling some of the patients that we see now, increasing numbers of patients with multiple chronic illnesses. They're very sick. We don't get the easy stuff anymore. You have to remember there's a lot of retail clinics that have popped up out there. I think you all wear these in the grocery stores or the Walmarts or the pharmacies. In the retail clinics, they provide what people want. They provide accessibility, affordable price, predictable price. The price is up on the wall like a McDonald's. That's what people want, and they're getting the easy stuff. they're getting the easy stuff that we used to see a lot of, and now most of the patients that are coming to a comprehensive primary care center like ours or to a private primary care doctor's office have a lot of problems, and they're very sick. And even these newly insured folks, and it takes us more time. So primary care practices are not as accessible as we would like to be because we don't have enough docs. It's hard to get people who are willing to work late at night. We compete with retail clinics. We have hospitals hiring primary care docs. Primary care as an industry, if you will, hasn't really risen up in my mind to meet the challenge that's out there is to provide better accessibility. We have a long way to go to get there. And that's one of the challenges. Besides the fact that there's only a limited number of primary care residency slots, and you really can't manufacture more family practice, internal medicine docs, right? Which is really what we need right now. It takes a decade to do that.
Can I just raise one radical solution that I've seen some journalists do around the country in terms of the question of accessibility and who will take Medicaid patients, and that is do surveys of dentists, for instance, in their area and start printing the names of ones who refuse to take Medicaid or poor patients. You think we're at a point where in Kentucky that would help?
I'm not going to answer that directly. I'm going to come back to it. Right now, we really don't have a good head count of docs and dentists and psychologists and nurse practitioners, PAs, because the licensure boards collect information in different ways, and that's where we have to go to get information. We really don't know how many that are currently licensed in Kentucky are actively practicing, how many are in administration, teaching, what their hours of operations are, whether they take Medicaid, whether they take new patients. And so we're flying a little bit in the dark, and the state will tell you this. I think there needs to be an effort to get the licensure boards to collect more of this information before we can, I guess, humble them.
You must hear stories.
Well, we know there are shortages of primary care providers all across the state, but we don't have good numbers.
I actually think that calling provider listings is a good idea. We flushed out years ago a network that UK was using that listed psychiatrists who were dead, hadn't taken a new patient in umpteen years. I mean, seriously, they were looking at moving to a whole new provider, and they had a phantom network. And I think they exist. And we've been trying to work with the MCOs to get those head counts. And, of course, we have 5 MCOs, so you don't know whether that one psychologist is at all 5 networks, so you're not getting the kind of data that you really need. And one way to do it is and we have our consumers call, because if you have both a behavioral health diagnosis and a physical health diagnosis, which is most often the case, you really have a hard time getting somebody to see you. So I actually think that it's a great idea to call and check out, do these providers really exist?
How many of you in here were born in the 30s? Except me. I doubt if probably nobody in the room. But when I never had access to health care until I went in the military when I was 17 years old. Nothing, but you went to a doctor, you sat in a chair, and you moved around as he took another patient in. You got sick and he couldn't get into the office, he'd come to your house, it cost $3. You know the problem? We didn't have the $3. So he had to take 2 dozen eggs and some chickens or something like that, And he only had a little coop. His name was Peter Gunnerman. Never forget him. He's a super guy. But I remember growing up, there were quarantine signs all over our neighborhood for measles, mumps, chicken pox, scarlet fever, you name it. Now, how many of them have experienced that here lately, other than the people out in California that had the measles outbreak? That's because people don't want to be inoculate their children because they've heard some bad rumors about inoculations. So they get scared and they get away from it. Some religions don't allow their members to become inoculated. And Paul Mason and I tried to change that there, and God, I run into I never knew there were so many Bible toters out there, and kept us from doing it. And but if those people get sick, everybody in this room gets sick because it's been a long time since you were inoculated, and they may not be effective anymore. So we've got to continually focus on those types of things that that keeps us healthy. And I think we should make it a condition of licensure that maybe doctors and nurse practitioners practice so many years in a rural area where it's underserved, instead of all of them coming to Louisville or maybe Lexington, Northern Kentucky, something like that. It's fortunate we have a highway system that can take us there pretty quick, but people want to. It's like schools. They want some that's close to them, someone they can identify with, somebody that knows their needs, and they need doctors. They need nurse practitioners and nurses in their community. And I don't know anybody that. Usually, the schools are not good in those particular areas, and the conditions around them are not good. If you go to Eastern Kentucky or maybe even down some parts of Southern and Western Kentucky, there are still farm areas out there, and so it's hard to get people to want to give up city life and go down there and stay for a number of years. But you can say pay their tuition if they'll agree to serve 4 years in an area. In the Second World War, we had medical students at U of L who did not finish their last year, and they became doctors immediately because they went into service and became doctors. And we don't do that anymore. And of course, we don't have to do that right now. But we need to make conditions available for primary care doctors. We need more of them out in the field. And pay their tuition. I don't mind doing that there. In the long run, it saves money along the run. And nurse practitioners help them along. And I think we have to change how we think about these things in order to get them to function, even with the General Assembly. I mean, it's hard to get the, most General Assembly members are never been exposed to some of the things we see out in this state. And that's enough.
Well, I was going to ask, we're talking about, an environment where we can attract more primary care physicians. What do you think needs to change in order for Kentucky to be able to attract more primary care? I mean, is it a better tort environment? Is it, tuition assistance? Is it some sort of program that the General Assembly could partner with the health community on? What do you think would generate maybe more interest in coming to Kentucky?
Of course, what we hear so often is about the high cost of medical education, and that newly trained physicians really can't make enough money to pay back all their loans in primary care, so they go into the higher paid specialties or subspecialties. So having some type of scholarships or loan repayments to retain those doctors who are trained in Kentucky, to keep them in Kentucky, would go a long way. I mean, the National Health Service Corps is still out there, but those are competitions across states. I know there is a state rural loan repayment program now, but I think if it were expanded and increased, we would have a better chance of keeping those primary care doctors that we train in Kentucky. And of course, it would be in turn for service in a medically underserved or health profession shortage area. I think that could help.
So many of the people who talk to us about the Affordable Care Act are politicians who have an axe to grind. So it's either a calamity or it's a godsend. I'm trying to get a feel as a journalist for what pressure points we can check to determine, based on data, based on facts, how successful it's been so far. And you all have mentioned some today. You've mentioned the rates of the population that has insurance or doesn't have insurance. And in Kentucky, obviously, we now have a lot more people with insurance. You've mentioned the cost of private insurance plans, which unfortunately has not gone down under ACA. You've also mentioned preventative screening, which people have greater access to. So those are three good examples. Can you think of other examples of pressure points, of things we should be checking to determine how successful ACA is? And can you think of what good sources of data we might go to for that information?
I want to just say the reason we're running around with this mic is not because in a small room like this you can't hear. It's because Al has a podcast going, and this is the only way we can get to that as well. So,
Well, I think the corollary to the rate of uninsurance going down is also a fall in the uncompensated care provided by hospitals and by other traditional providers, the safety net providers, and that's being documented, has been documented. And there are savings then that accrue to state and local governments when that happens. I know just in Louisville alone, the city of Louisville saved nearly $9 million or so this year with reductions in payments that they make to the hospital and to the health centers as a result of the drop in uncompensated care. So that's a hard number. And I think the hospitals are all across the state are reporting that drop in uncompensated care. I think you could look at employment figures. Healthcare employment's growing. Now, is that a good thing? Well, from an economic development standpoint, yeah, healthcare employment's growing in the state, and I think that's contributing to the tax rolls, and that's one of the factors that Governor Beshear's report took into account when they looked at the total impact of the state, the cost impact.
Hi, Rich Seikel. I'm with Kentucky Equal Justice Center. One of the big stories about Kentucky in the last couple of weeks was the increase in coverage as verified by the census data. And, from the cost point of view, that might sound scary, but I'm struck by the fact that so many of the strategies that you talked about for bending the cost curve presumed coverage, that people have primary care providers, that they get substance abuse treatment and that kind of thing. So I'm thinking back to that map that showed Kentucky's sort of standing out in the South as having coverage now. And in my mind right now, that creates an opportunity to try these cost-saving things. We got to be smart about it. We got to have the data to know where it's going. So I think the story I'd love to see is about, creative strategies that get people the care they need, that save costs later on. And they may be hard to find, but I'd love to read them.
Hi, I'm Mallory Powell. I'm the communications director for a research center at UK and a freelance journalist. And we've talked a lot about care delivery and how that's been affected by healthcare reform. But I'm looking at our PowerPoint screen and we're talking about a healthy Kentucky. And I'm wondering, from your perspective, what's being done to, as the Robert Wood Johnson Foundation is focusing on lately, creating a culture of health, because so much of our health issues aren't occurring at points of care delivery. They're what we eat, they're how we live, they're how we conduct our lives. So what's happening from your perspective in terms of creating a culture of health in Kentucky, and what's not happening that should be happening?
Al Cross says it's an excellent question.
It is an excellent question, and I think that if you go back to some of the initiatives, for instance, the Foundation for a Healthy Kentucky has funded in terms of healthy communities. I'm thinking about Dave Atkinson, who is now the CEO of Kentucky Chamber of Commerce, and when he was in Owensboro, created green spaces and walking sidewalks and so forth. If you look at what's happened with just the focus on junk food in the schools and that fight in the legislature, but was actually an education piece around what do we need to do healthy eating in our schools and get rid of the I started to say slot machines, the Coke machines and so forth. And, we had to fight the football teams and the pep bands because that was a way of funding those. I think one of the things that's happened is, and Dr. Lee Todd, who was at the time the UK president, called them the Kentucky Uglies, and we've talked about that. And almost every Kentuckian knows that we rank at the bottom on almost every measure of health, right? Except we're at the top in smoking and the bad behaviors. And so I think there's been, in many ways, and even though it's been politicized, there's been more discussion about health in Kentucky in the last couple of years, not just about Obamacare or the Affordable Care Act, but combined with that history of talking about the Kentucky Uglies and small communities. Another factor is the work that's been done around smoke-free communities. Think about the number of individual communities who have been educated about what happens health-wise with secondhand smoke, and whether we ever pass one, and I hope we do pass a statewide comprehensive smoking ban. The governor has done a great job actually in making the state park and all the office buildings smoke-free. So I don't know that it's coordinated, but it feels to me, and I think you're exactly right, we need to be talking about, the terminology now is population health. Okay, everything's about population health. That's what your health departments are really focusing on. That's what really the ACOs are focusing on. So the population is made up, obviously, of all these individuals, but it really takes in that kind of culture and environment. Julie?
Yeah, and I would like to just speak about one issue relative to your question, and that is smoke-free. I was the primary sponsor for smoke-free in the city of Louisville, and then I've carried the smoke-free bill in the General Assembly every year because I think that's just one example of where we can have a tremendous amount of savings. We can save over 5 years $2 billion if we implement a smoke-free Kentucky. And I tell my colleagues all the time, when you're talking about $2 billion, that rises to the level of a statewide issue. It no longer is a community-based issue. And I think one of the things that I try to impress upon my colleagues is that we have to start looking at health issues in terms of rising to the level of a statewide issue, because the costs are so significant, not only personally, people suffering from various ailments, but from a budgetary standpoint. And so I think the media can do a great job in talking about those health issues as rising to the level of a statewide response. And it also, there's an advocacy component. I mean, just from your outside of your professional responsibility, your personal responsibility, and that is call your elected official and say, I'm really passionate about health issues. I do this professionally, but personally I want to tell you that I think that, we need to have a smoke-free, or we need to have, fund diabetic screenings, and we need to have more outreach and all of these things that cost us money in the long run.
Let's see, I'm going to ditto that there. Because 28% of our adults in Kentucky smoke. We're the highest in the country. Number one. Isn't that terrible? The number one and one of the most serious health problems we have. Contributes to people with diabetes have a serious problem if they smoke. It causes problems with your heart, your lungs, your kidneys, everything in your body. And yet we steer away from it. One is because we raise a lot of tobacco in Kentucky. I did a bill back in the early 80s to stop smoking and prevent children from smoking. Where did he put the bill? In the Agricultural Committee. So when I went with the people from the Heart Foundation and we were before the committee, before I even opened my mouth, every member of that committee lit up a cigarette. Now, this is fun. So I told the people who had me sponsor the bill, I said, I think the bill's in serious problem. And it was. Couldn't even get a motion to move it out. And secondly, of course, if you can't get a motion, you're not going to get a second either. Consequently, the bill died. I've sponsored the Smoke-Free Kentucky a couple of times, and we've had some very good sponsors behind that do it. I thought we had our best chance last session of Susan Westrom brought it to the House and did a great deal of work for 2 years to get it passed. And I think Julie handled it over on the Senate side. And I thought we'd pass at that time, but we didn't. And anybody remember Johnny's Restaurant there in Louisville? He was worried. I went in there. I used to go there quite often, as a matter of fact. And I told him, I said, John, I'm not coming here anymore because I'm sitting at a table and the guy next to the table is blowing smoke in my face. And I said, you can't enjoy dinner or anything like that. And then when we passed the ordinance, the local ordinance, that he says, oh my God, I'm going to lose my business and everything. I said, I'll tell you one thing, John, your business will increase by 15%. Guess what? It did increase by 15%. And I was in Rhode Island. They passed one that's statewide, smoke-free. And I said, didn't this bother you? No, it doesn't bother our business. They wouldn't allow us smoking outside in some areas, in public places. They won't allow them to smoke outside. So, this is one of the biggest health problems we got in Kentucky and probably the states, and yet we kind of wink at it. We talk about it, but we don't mandate where one would be increase the tax on cigarettes. Every time we do that, smoking, people using cigarettes stops using them. And but we don't seem to have, now we're the lowest again, I think, in the country on our taxes on cigarettes. So, that's an area we can do. The sin tax always works. And particularly if we can keep our children from getting started on it. And I think this is one of the big things we got.
Yeah, just to wrap up that, there's certain things that the state can do, the state legislature can do to affect healthy behaviors through legislative action. I think a lot of the initiatives around creating healthier cultures are occurring at the local level because it's really hard to do. It's a very diverse, big state, urban, rural, a lot of variations. I know that the Friedel Committee and Rich Heine back there is working with local communities that try to adopt health initiatives at the local level. In Louisville, for instance, there's a lot of momentum there. Started with Dr. Nesbitt's Healthy Louisville 2020 plan, the mayor's Healthy Hometown movement. Lately, I know that Leadership Louisville's elected health as their priority issue for the next year for their initiative, and in part because they realize in order to grow the economy and you have to have a healthy workforce, and we're at a disadvantage. When companies looking to move to Kentucky or to Louisville look at our health, the uglies, and the cost of health care for covering those employees, they're going to be scared away. So even the business community is very involved. So I think there's a lot of small local initiatives that and we need to share the successes that are going on around the state.
I am also an advisor for the student newspaper at the University of Louisville, and then I'm also faculty advisor. Well, I'm on the board for that, and the advisor for the National Association of Black Journalists, the student chapter. So my question to you as it relates to that is, what are some story ideas that you all would have that would encourage students to kind of get on the bandwagon of writing stories about health? What are some topics that maybe you can suggest that would get them thinking about the importance of health, pretty much in line with the notion of prevention?
How about the fact that for that generation, they have a lower life expectancy than their parents? First time ever in the history of our country. So it's got to be real personal at that level to say, what is going on here, that I am looking at my parents, who I think of as old as the hills, and yet I'm being told that my life expectancy is less by 5 years, something like that, to make it really personal. I think the other thing is that there are a lot of student initiatives that we're seeing at even the grade school level or elementary level, but certainly at the high school level, where kids are taking ownership of healthy eating, of exercise, and some of those kinds of things. And I could picture students that you're working with really relating to those kinds of stories. The other story I'm fascinated about as a child psychologist is how many kids are saying to their parents, quit smoking. Get up off your duff and let's go for a walk. Kids are worried about losing their parents to these diseases. And I think there's some internal education that's going on, and they learn it at school for the first time. And I hear that from parents. They come home and say, I really do, I'm worried about you. I want you to quit smoking or get healthy, or, diabetes runs in our family, and what does that mean? Those kinds of things.
I think if we're talking about issues that students might be most interested in, their peer group, their age group, obviously issues that stand out to me is violence is a public health issue, in Louisville in particular. Increased suicide rate's going up. What's going on, And of course the substance abuse, and particularly heroin. And this is one that, we talk about a lot, and really concerns me because I think it's not widely understood that this cuts across all socioeconomic segments, all neighborhoods. If you look at the obituaries these days and you see these young people in there, you really don't know what's going on. So I'm really glad to see, and I hope somebody take this up, that in some other states people are beginning to put heroin overdose in the obituary so people see it's real. It's got a face. I would like to start a movement to do that.
Just one more issue to add to the list, and it's part of what Bill was talking about. I think that it's tough to interest young people in issues like cancer and heart attacks, where their rates aren't going to start rising for a long time. But I think the issue of mental illness generally is extraordinary on college campuses, and the lack of treatment options is amazing. And so and if anybody's going to do an issue on that, they ought to go directly in the next 2 months to the guy who runs the National Institute of Mental Health, who cares deeply about what's going on college campuses, only he's quitting to go to work for Google in about 2 months. So his name is Tom Insel.
It's called stigma, STIGMA. And we are fighting it every moment of every day. When I was in practice in Louisville, people would bring their kids to see me, and they would sit with the newspaper hiding their face in my waiting room, lest anyone know that they were bringing their child to see a child psychologist. It keeps people, we have 1 in 4 are going to have a mental health or substance use disorder sometime in their lifetime. And I use that statistics in a legislative hearing, and you could have heard a pin drop as the 15 legislators up there were kind of looking to see who they thought it might be among their group. 1 in 5 used to be. Now we're saying 1 in 4. Only a third, if that many, seek treatment. So the issue really is stigma. And the more people write about it, the more you have that face on it, the more the kid tells the story about how there was a TED Talk on NPR over the weekend, if any of you heard it, a young man, 19 years old, who talked about writing his suicide note and coming really close to successfully suiciding. And he told this story in what he thought was going to be a small TED gathering, and it's had, 500,000, 1 million hits because of the number of youth that are resonating with that. It's out there, folks.
It is out there. And if the statistic is 1 in 4 nationwide, I'm convinced in most newsrooms it's 1 in 3 or 1 in 2. And when you write or report on these things, your editors will come up to you and tell you, I've never had more people come up and tell me, I've had this, or somebody close to me. So try suggesting it as a story and people will respond. There was a question here.
My name is Mona Huff, and I'm a community organizer. I started quite a few years ago in my community, being concerned about what was happening in the community. We started, first of all, with a diabetes coalition, and I found out that management, prevention, education, those are the important things, and they need to be made affordable. They need to be free. They need for our healthcare providers to believe in them and to be able to refer those folks to us. We are now expanding our coalition. Our funding through CDC and the Kept to Rule Diabetes Coalition ends September 30th. And the coalition in Henry County has changed their name to Health and Wellness Coalition because we plan to expand to other things. some of the thoughts that's come across my mind as I've heard the different comments is that we need a whole system change. Our health care is impossible for most of our folks to even understand, let alone to be able to afford. I think the countries that the gentleman was referring to, that they are able to provide health care for their folks, and why we in America cannot, goes back to some of the things he was saying back in the 30s and 40s for me. I'm probably the second oldest in the room, is that we have made making a living to making a killing in providing health care. We're no longer considered a service agent, but who can make the most money? The cost of education for a person to become a doctor or a nurse is out of sight. The cost of research is incredibly unrealistic. The liability insurance for these folks that are trying to provide coverage. I worked for a doctor way back in '65. First year he brought in $100,000 into his practice. That was not his income. That was the entire practice. Now he would not be able to get liability insurance for that amount, let alone run his business with that amount. The cost of running a business is incredibly high for these folks. So what do? Obviously, it's not going to be easy, but one of the things that I think that we can do is for our folks to start working at the top of the responsibility of their degree and look at folks in the community, such as community health workers, to help them with the rest. I can do an incredible class on diabetes education, but I perhaps can't be the one to diagnose that. And if we start working out into our communities and using our folks who have learned how to manage those chronic diseases as facilitators and as encouragers and as mentors, we can see incredible things happen. I could give you story after story how folks with A1Cs off the chart are now normal, how people have lost 100 pounds plus, and it didn't cost an incredible amount of money, an incredible amount of time and patience, yes, but not money. So there are some cost savings, there are some strategies. I think we need to, and I would challenge our legislators to look at the Vermont model. I've taken all that information to Senator Hornbeck and to Representative Rick Rand, and I've offered, I want to come and talk. I mean, I'm not a very smart person, but I do know that things are out of hand, and we as grassroots have to do something about it. Also, to my insurance companies, I would say when you see someone who's getting well, find out why they're getting well. In '99 and 2004, when I was at the height of my illnesses, I was taking 11 pills and insulin to scale. I learned about health. I did my own research. Unfortunately, my doctor never suggested it. And I became healthy. I was paying $1,100 every 3 months for my portion of my medications. I don't know what the insurance company paid. Probably have a heart attack if I knew. Today, I pay $10 every 3 months for a lone little thyroid pill because I learned to manage a couple of chronic diseases and not expect the doctor just to keep giving me an additional pill with all the additional side effects that I need another pill to take care of that side effect. Okay, I'm through preaching.
Next time you're on our panel, let's see. Okay. So we have time for exactly one more question here. Did you have? You did, okay.
My name is Rachel Bruger. I'm with i5 Publishing. I'm an editor. Kind of building off of what everyone has been saying and asking, what is the Affordable Health Care Act doing, or is anyone talking about how to bring in these alternative health care options that aren't being covered by insurance and are way cheaper and would help, people get healthy without having to push pills and expensive treatments?
Yeah, that's tough. I'm not. Are you talking about alternative and complementary types of medicines? Like, could you give us an example of one that you might have in mind? Yeah. Right. Well, I don't know how the others might respond to that. We are trying to expand access through our health centers to different non-medical modalities of treatment. Focus on we offer yoga classes. We obviously emphasize. We have physical therapy clinics. We have Roomba. I mean, we're trying to focus on prevention and wellness as well, not just dispensing pills, not writing prescriptions, which has been so often what the primary tool in the tool bag of a primary care doctor. But now we have teams of providers, to your point, working at the top of their license so that the physician can manage a larger panel of patients. But to me, everything comes back around to health literacy. We need to educate the public about how to use their new benefit, as Sheila mentioned. We need to teach them how to utilize the healthcare system itself, and we need to teach them more about healthy lifestyles and healthy behaviors, how they can take more responsibility for their own health. This all falls under the umbrella of health literacy. To me, I agree the system is way too complicated. It's very difficult for people to navigate, for the general public. Even me, I'm in the field every day. It's difficult for me to understand. So I'd like to think that we could simplify and get back to some of the basic stuff.
I'll speak for the legislators and tell you that there are fights every session as more and more groups come and want to get mandated into insurance coverage and so forth. That's probably not the solution, because every time you add a provider group, you really do drive up premium cost and so forth. There is a piece of help that's out there that I think we're not using nearly often enough, whether you call them community health workers, system navigators. In the behavioral health world, they're called peer support specialists. They're the person that reaches out with a newly diagnosed person and says, been there, done that. I have that same issue, or I have that in my family, and here's what we're going to do, and here's why it's important to keep this appointment, do this and that. So that's one piece. The other are support groups. I am amazed at how infrequently a primary care provider or a specialist, even though you're diagnosed with diabetes or whatever, or you've got a family member with Parkinson's, says, you know what, would really be helpful for you to get additional information and support. And there's a Parkinson's group here for patients. There's one here for family members, or, that kind of thing. If you look in the Courier on any given day, there's a whole listing of them. I don't know out in the rural areas whether they're as available. I refer people all the time to our NAMI groups. That's National Alliance on Mental Illness. We have 23 chapters across Kentucky. Picture that your adult son, who was a star quarterback and at the Naval Academy, who's now had a psychotic break and has a diagnosis of schizophrenia, and how lost you are. And to be able to talk to other parents who have been there, done that, and are continuing to work on that, saves healthcare costs all the way around, I think. So those are some things that I think are not in the system that we could count, but we really need to be paying attention to.
We have in our health journalism program in Boston 2 traditions when we end a session. The first one is to give a round of applause for an extraordinary panel like we just had. And after we throw them a bouquet, we ask all of our panelists or speakers for their most intimate contact details so we can get back in touch with them if they have questions. How's the best way for people to reach you if they have questions on these story follow-ups?
One is by the telephone. Secondly, just stop by my house anytime I'm at home.
What number?
Oh, you have to give the number? Yeah. I'm not going to give you my 502-454-4002. I'm there 7 days a week. And every Saturday I have open meetings at my house if you want to drop by. And if I'm there during the week, you can drop by anytime you want to. This is a full-time job at half-time pay, and but I love it. In fact, when I first went to journalism, I didn't even know it paid a salary, and I was pretty close to right. It paid $300 a month, and you got $10,000 worth of hell every day of the year. but I love it. It's a good job, and when you can just make it work a little bit, it's very satisfying. I want to share one thing, if I can. When Gerda Bidwell was chair of Health and Welfare, she did a bill on spouse abuse. And the thing was, it was going down to Raymond Overstreet and Hubie Deskins were just tearing it apart. They felt like, my home is my castle, and I have a right to beat my wife if I want to. These are legislators I thought a lot of, actually, but they were having fun with it. They thought, they would kill the bill anyway, and it was dying. And what it takes is people who have experienced something like that to get up and talk about it. I stood up, and I don't know what made me do it. And I said, how many people in this chamber have been abused? Hold your hand up. And I did. I was the only one. And I started talking about it. And we passed the bill. Passed it in both chambers, as a matter of fact. What makes the job so great, I never thought any more about it after it passed. I got a note in the mail, and this woman said, Representative Birch, I was in the chamber when you got up and started talking, and I could see the mood of the General Assembly change. And you passed the bill. And that, to me, is one of the most satisfying. That's what makes the job worthwhile. And I know Julie's the same way. You get a letter where you did something and you helped somebody. But after it was over, I had 5 legislators come to me. I know what you're talking about. I was abused. I said, why did you get up and help me? Embarrassed to talk about it. And this is the thing that I think public officials should talk about. If you've experienced it, talk about it, because everybody thinks we live a sheltered life, and we have problems too, believe it or not, just like everybody else does, and sometimes worse than other people do. But because you're in the public eye, you want to keep this down, and you don't want to talk about it, and you don't want it out. But just getting a note once in a while in the mail saying thank you for what you do, it just makes the whole job worthwhile.
I'll give out my contact information too, but along the same lines of Tom, you run for this job because you're passionate about public policy and what you want to do. And I remember one time, it was my very first committee meeting, and it was the education committee meeting. We were talking about funding and staffing levels and this, and I remember I asked the Department of Education, I said, well, we have these contiguous counties where we have declining enrollments, yet we have staffing levels the same. Have we thought about maybe merging these, contiguous counties with declining enrollment, and that way we can save some money, make sure we get it back into the classroom? And he didn't answer. And then another state rep raised her hand, and she said, well, unlike Representative Adams, I'm pro-education. And that was kind of an eye-opener to me, because I realized pretty quickly on that if you ask questions, or if you go against the norm, or you kind of, swim against the stream, then you're going to be labeled a certain way. And I think that while we all have passion for public service, it is our responsibility to ask, can we do better? Can we improve that delivery system? Can we make a difference over here? And sometimes uncomfortable questions are the best questions to ask, because we can do better. I truly go to work every day because I think we can do better. And so with that, please call me. I do not like my LRC email, so I always tell people to email me at home, and it's Julie R. Adams at twc.com. Don't forget the R. And then my cell phone, I also am a good texter. So my cell phone is 502-744-9264.
And that's how you know a legislator likes you, is when you get their cell phone number. That's true. My email address is kyadvocacy, kyadvocacy @gmail.com. That's kind of my, for all the umbrella organizations that I run, that's the umbrella. And my cell phone is 502 836 4222. And I am an accomplished texter because my grandchildren have worked with me. I learned early on from my daughter, who is a health educator, big on health literacy. Mom, don't call me and then immediately text me. Do one or the other, but a little overload here. I was so excited about texting, so feel free to text.
Thank you. My kids don't answer the phone when I call them, but they'll respond immediately to my text. So I'll give my cell phone as well, but I have some business cards up here if anybody would like them. My cell is 502-485-9215. Text, please. And my email is bwagner, BWAGNER, at FHC, which is initials for Family Health Center, Louisville.org. So it's bwagner at FHCLouisville.org. And I have some business cards up here if anyone would like to pick one up. And I just want to say it was an honor to be up here. These are some of my advocacy and policy and legislative heroes. So I'm just glad to be here today. Thank you for inviting me.
Glad you were here. So what we're going to do is take a 5-minute break, and then we're going to reconvene here for our next session. Thanks.
Wow. Thank you.
Thank you. Yeah.
Thank you. Sorry about the. No. It did come from some.
It's all okay. It's all okay.
Thank you very
much. Yes, thank you. Yeah, hopefully it was helpful. Yeah. Absolutely. Yeah. Ken Handler, welcome to Kentucky.
Yeah. You think I'd make it here, did you?
I wondered about you.
I said a few years ago, be offered to be a reported resident. You thought I was joking.
Well, it's good to see you again. Thank you. Was that one of your students that asked that actual question?
No, it's actually a UK employee. We have to stick together.
Right on target.
Thanks for coming. Good contribution.
Thank you.
Job market.
Yes, it's one of our great rock bands. Get people in a locality who feel like they're not getting their just desserts from the county government. Ask friends in the legislature to get a bill passed. I tell a lot of Kentucky counties.
Sounds like Arizona.
I imagine it's fairly typical.
Yeah, that's statewide. Lawmakers have national reputation for the wrong reason. Looks like move to the state. You know what's going on with that?
There's no effective editorial page. Every now and then it'll be an editorial. And dinner with the editor last night, planning to hire someone to perform that function. But really dismayed a lot of people in town because he used to have a very strong editorial voice. Waiting until he finds some money.
So I don't want to get numbers wrong. How many years? 26. It is 26. And last 15 plus.
Been in UK for 11. Yeah, it was a good thing. A couple of stories out of it.
Going to trade those
I did.
Glad to have you.
Thanks. Good to be back.
We had a really good panel on the road opportunities. Beyond that, I'm not sure how good the program was. Next year, New Orleans.
Yeah. Hi. Louisville Public Media, meaning the FPL. So I just met Gabe, is it Gabe Bullitt, who was up there doing an EMIN, and he was a very good guy. But he left you, and that's sad. Just, first of all, let me write down here the... So the way to make it hot is we have half the reporters saying it's from FPL. I have a particular bias in favor of anything Louisville related, and I'm a big FPL
Maybe a little bit more than
so the sending notification, go to the website listed here, and I'll tell you how to do it. So if we could grab our seats again, we're going to get started with... It is our...
Everybody's, it's like these
dinners
that now have the hour-and-a-half cocktail party.
Exactly. Journalist is... Okay, we're about to begin. Thank you. So everybody ready for the next session? Thank you. So to be here with you today, I came a long way from Boston, and I would have come, there was one single thing that would have drawn me here more than anything else, and it was the chance to get in the first word and maybe the last word on Al Cross, which I tried to do for all my years at the Courier-Journal. And I'm convinced, actually, I was convinced when I first came to Louisville writing for the newspaper that there had to be 3 Al Crosses. There was the Al Cross who covered his geographic beat when I got there. There was the Al Cross who was my shadow covering environmental issues. And there was the Al Cross who did a better job covering politics than anybody at the paper before he was designated as political reporter. And there are still 3 Al Crosses, and I want to introduce all of them to you right now. Al spent 26 years at the Courier-Journal, where he's done everything from environment to covering eastern Kentucky, to the last 15-plus years a chief political writer, which is a venerated position, and he is about the only person in an era when the Courier-Journal barely has an editorial page. He's about the only person whose voice you can still hear consistently there. For the last decade, he's run something called the Institute for Rural Journalism and Community Issues at the University of Kentucky, and he's been an assistant professor, and he likes to call him an associate professor now, and he tries to get the last word. He also calls himself, I think quite accurately, an extension agent for rural journalists. And he has been just about everybody I know, young journalists in Kentucky and older ones like me, he's been their mentor. And Al taught me everything from where eastern Kentucky was to how to pronounce the word Louisville to generally what really caring about journalism. This is a guy who's run national journalism organizations and ones that are very, very community-oriented in Kentucky. He cares about Kentucky. He cares about journalism. And today his mission is to talk to you about issues that ought to be covered in terms of the ongoing coverage of health reform in the state? Al Cross.
Thank you very much, Larry. That's a little too fulsome, but I'll take it. You know, in all my years of covering politics and government, I avoided health issues like the plague. It was just too complicated. I said, you know, don't give me that stuff. You know, hand it off to somebody else. Well, thanks to the Foundation for Healthy Kentucky, I have immersed myself in health issues the last 4 or 5 years, and there's probably no better state in which to do that because of the status of Kentucky's health and what the state administration has done to embrace the Patient Protection and Affordable Care Act. I always try to use the long name. My job is to give you an idea of how we got here and where we're going. Typically, this would be an initial presentation at a workshop, but we had to accommodate the schedules of the panel. So first you get the opinions, and then you get the facts, or at least I hope they're facts. We have enough people in the crowd who I'm sure will correct me if I get something wrong. So please feel free. So what got us here? Why do we have a Patient Protection and Affordable Care Act? Well, more than 30 million people and about a fifth of Kentucky's population didn't have any coverage. It's not a good thing. The insurance companies had restrictions, which people on the panel mentioned. So that just made our health even worse. You know, health problems went undiagnosed, and the taxpayers and the ratepayers and individuals had to pay these horrible costs. And you had the lifetime limitations, and people who bought these cheapy insurance policies with them had, you know, they went into bankruptcy as a result. Left them holding the bag. So the goals, as I interpret them, of the PPACA were access, to make health coverage available to everybody, adequacy, you got to set minimum standards for policy. This is really important. I think the Act really is more insurance reform than health reform. It plays an important role in reforming the healthcare system, but as far as where the rubber meets the road, where consumers are affected, it's insurance reform, because most people just pay insurance premiums and don't really use the healthcare system that much. So you got to set minimum standards, don't leave people holding the bag, and pay for screening. Free screenings. Affordability. You subsidize private health insurance through tax credits, and you expand Medicaid up to 138% of the poverty line for people to get coverage, free coverage. Those, I think, are the 4 basic premises of the Act. So how did Kentucky respond to the Act? As Bill Wagner mentioned, he dropped the F-bomb when he saw that Medicaid expansion would be optional. Well, generally, if you live in a Republican state in this country, Medicaid has not been expanded, although some Republican governors have done so. Our response, the state created its own health insurance exchange, which we all know as Connect.